General practice finance is, let's be honest, a little bit confusing at times. There's so many different pots of money, so many different things that you can do that figuring it all out would just, well, it's really complicated. It'd be nice if there was a little document that helped you kind of understand what you're getting in your own practice and stuff. Well, rather interestingly, NHS England have providers with a ready reckoner that basically allows you to do all of that. And we're going to walk you through it in this really short episode and show you how you can figure out your practice finance, hopefully a little bit easier. Let's tech enhance your primary care and learning. Hey GP learners, welcome to this episode with myself and Andy as we crack through showing you what a ready reckoner from NHS England looks like in terms of your practice-based finance for 22-23. How are we doing there, Andy?
Yeah, not too bad. I mean, it's that time of year, isn't it, when we're all beginning to try and forecast our budgets in general practice for both our practices and our primary care networks, moving through to the next financial year. Obviously, we're recording this at the beginning of April, so that's where our heads are at the moment. And it can be really difficult when the tariff for the GMS contract and QOF points and all sorts of things relating to primary care network funding does change year on year. There are little uplifts here, things are removed, things change here and there. So it can be really difficult to predict what will be coming in. And NHS England have quite helpfully provided a ready reckoner document to help practices through this task. So we're going to be having a look at that really. So I guess first of all, we'll show you where you can find the document. We will link it in the show notes below. So if we just pop up on screen, so there's all sorts of new documents landing about the GP contract, and we talked about that in our last episode, and we'll be looking at some more of those going forwards in future episodes as well. But if you look at the financial information section, click through, and then there's this document here, which is the Ready Reckoner, and you can download that to your PC. It's an Excel spreadsheet, and you can play around with it really. And we've done just that, and we have it here. Yeah. So it's quite simple. There's just 3 tabs. Tab 1 talks you through what the objectives of this spreadsheet are, and it just highlights some of the changes actually in terms of the sums moving from last year 21-22 tax year to the 22-23 tax year, just indicating that the global sum has gone up. And I think I've not got my calculator actually, but we were supposed to get a 3.1% rise in the global sum, and I believe that's roughly what is indicated here. QOF points have gone up by a similar amount as well, and these are all summarised in their BMA GP contract changes website, and we'll have done a video about that as well, which we may link below too. The amount that we have to pay from global sum for out of hours subcontracting for those practices, and I think most practices do subcontract that to a local provider, remains the same, and the network payment for participating in the network DES is the same. I don't think that's actually gone up since the inception of the network DES. And then it just talks us through a few other sort of caveats and so forth about the funding, which I think people can probably get into the weeds of and have a look at their leisure. So any observations or comments before we move on to page 2 and start doing some calculations again?
No, it's fairly self-explanatory. It just sets the tone for the following tab, which is actually the meat and bones of this Ready Reckoner, and basically where you're going to spend most of your time, which is working out your practice finance.
Absolutely. So so a lot of those figures kind of carry through to the calculations on this page of the spreadsheet. So so shall we go through with a kind of a fictional practice?
Yes.
Roughly about 10,000 patients. We'll say that it's in a deprived area because that's where Gandhi and I generally tend to work. So we'll say that the Carl Health formula multiplier is 1.1 to give you your so that's the number by which you would multiply your raw patient population by to give you your weighted or adjusted patient population.
And just to point out, at one point we do have to use an actual use of data from a practice or a network and stuff. So in that point we are going to identify which it is, but for the rest of it we have used fake data. So this is not necessarily a real practice, but is not atypical in terms of practice that we would see in our particular area and things. So as Andy mentioned, we're starting off with a raw list size of 11,000 basically, and that becomes weighted at 12,100, and that's based off a previous practice population of it being 10,000 the year before, so showing an increase in population size, which most practices probably have seen some sort of shift and change in that respect, and that gives us basically the figures that we're going to be working with.
So just important to make sure you get the right figures in the right boxes here, and it does tell you. So this first box is average weighted patient size 21-22, and average weighted size 22, 23, because that powers your global sum calculation.
Yeah.
And then it asks you basically for the same figures here and here. So in the last tax year and the coming tax year, but unweighted. And that actually powers the QOF calculations because they're not, there's some prevalence weighting within the QOF calculations and they're not weighted according to your kind of deprivation factors in your practice. So you enter those figures in. And then there's two things. So just to note, it's very helpful. The yellow boxes are basically where you're putting data in. So this gives you, this is it, basically the ready reckoner for funding in the coming tax year. Now, you just have to be careful. So these figures, you enter your, into these yellow cells, you enter your practice performance information from last year, so 21 to 22. I mean, that's if you've got it, depends on when your account year closes and when you get your accounts in and so forth, but you probably have an idea of what you've expected to have got in at least. In these areas. Now, just be careful. The initial spreadsheet comes with quite a low figure for QOF achievement for the data that's in there. So we had to do a calculation to make that more realistic for a practice of this size. We've probably over-egged it here because I think they've got about a 99% QOF achievement, which might not be achievable for the sort of practice that we've described in the sort of area that it's operating. But that's the data that we've used. So you put in the performance for the previous years. It then uses the calculations to predict what you would get from QOF this year. Now with this one, it actually makes some assumptions about your performance last year, your achievement last year, based on the figure you put in here. And so that's a large part of what drives this, as well as just the raw calculations based on list size and the value of QOF points and the availability of number of QOF points. So it shows you what you might get in the coming year, and it tells you what the difference is. So very helpful. The situation for the global sum is a little bit simpler in terms of it just uses the amount that you get from for the global sum and the population size there, but allows you to compare with your achievement last year and tells you the difference. Out of hours deductions are then deducted from your global sum, giving you a net global sum here. And then it just adds in your network participation payment. So just remind you that that is a separate payment, and your primary care network probably has certain expectations about participation in the network DES based on the receipt of that £1.76. And then it tells you your net income. So most people will be interested in this column here. So indicative funding from April 2022. So it's 1.3 million for this practice here. And that's an increase in 148,500 from the year before. So that's how it works, really. It's really high level numbers. But I think for a lot of practices, it will be useful. If only to compare with perhaps internal kind of projections that you might be doing yourself. So any thoughts on that, Gandhi?
No, it's fairly self-explanatory. It does give us a bit more information later down the line, some of the impacts with primary care networks and stuff, doesn't it, as well, Andy? So just being aware of the additional stuff that you get here, as you can see. So then it talks about...
So this is where you enter your data. So as before, the yellow cells are where you need to input data. So it lets you put in the population for your primary care network, both raw and weighted. I've used the same figure for both here. I wasn't quite sure what the weighting might be for this particular primary care network. Now, for some of the calculations, you are required to indicate which primary care network you are talking about. And it's actually impossible to make up a figure to put in here. It's dependent on indicating a specific primary care network that you're dealing with. So we've used Gandhi's primary care network in Nottingham East primary care network in Nottingham. And you have to select the name, and then you do need to know your U number. So
so your ODS code. And if you don't know your ODS code, well, your practice, your CD should know that. But if you don't, like I forgot ours, you can search for it. You just type into Google primary care network ODS code. It will take you to a web page that basically lets you search for it based on the name. So as long as you know the name, which hopefully you know the name of the network you're part of, you can find out the code.
Cool. So simples, really. So we'll just get back to the main body of the spreadsheet. So that the ODS code populates this with the actual adjusted population figure that will be used by NHS England for calculations going into 22-23. If we scroll down, so this will be quite useful information for Gandhi, and hopefully is similar to predictions that they might already be operating on, given a lot of the decisions for this year will have been made in the last few months. So it indicates the level of core funding there, so about 100,000. The level of funding available for clinical director or associated management
Yep.
activities that the PCN might choose to spend that on. So there might not just be one clinical director, some have co-clinical directors,
Yep,
deputy
like
clinical
we do.
directors,
Yeah.
which are often funded from the same pot.
Mhm.
Tells you the total available for additional roles reimbursement schemes. That's a huge number now, isn't it, Gandhi?
Yes, significantly increased. As it does mention in the PCN DES contract that number is going up, and next year it goes up even further. Although how much, I can't quite remember how much it goes up again next year, but it is a significant amount it goes up by.
Yeah, I think it ramps up by about 250 million nationally
Mhm.
each year, and quite how that translates to a local increase is a question of arithmetic, I guess. Don't know the
Yeah.
answer to that at the moment, but it is going up significantly. And of course, that's the amount that is available to draw down
Yes.
to pay staff, but that's contingent upon having recruited the right staff and having them enroll to then be able to draw it
From
down.
day one as well. So bearing in mind that each month you will build an accrual of a leftover pot, basically, and that's why every year there's an amount that people are scrambling around to try and make maximum use of for their patient populations and stuff.
Yeah, and it can be really, really challenging to recruit sufficiently to spend that money.
Yes.
And in fact, I think it's almost impossible, given that assumes that you are spending on all the staff you would recruit that year from day one, which
Yeah.
isn't really a impossible situation to be in.
Mhm.
Another area of funding for primary care networks is the funding for the care home element of the
Yep.
the DES, the care home sort of enhanced service element. So we'd said that this PCN has 250 beds. So we did actually pluck that number out of thin air. I'm not sure that's actually the right figure for.
Not far off it, if I remember rightly, but yeah.
So that's fine. So there's about £30,000 available for delivering what is actually quite a comprehensive amount of service
Yes.
needed to actually fulfil delivery of that part of the DES. And we've done other videos about the care home DES,
Yeah.
but it's not a lot of money considering what needs to be done to do that properly.
Mhm.
Then you look at the extended hours and extended access budgets.
Mhm.
And I'm just paying attention here actually just to see if they've combined them for this year within here,
They have not.
because they are combined going
Yes.
forwards for part of the year, but not all of the year,
Mm.
I guess. Is that right? Because
So it officially kicks off in October, so that's why the amount is probably different to what people are expecting. So most people are probably looking at expecting to see £7.44 as a moderated fire rate, and as you can see, it's £3.764 in the document, and that's because it kicks off officially from October, so there's half the year and stuff. But in terms of, I guess, following years, you just basically double that if it stays the same amount for next year, which we don't know.
So okay, so pay some attention to that area and supplement that with your own calculations. And then there's some assumptions around achieving the impact investment fund, and I believe these assume full achievement of the impact investment funds, which may or may not be realistic in your area. I'm not sure we'll all be achieving all of those points. There's a lot of work involved if you're going to do that. And I think we talked about targeting efforts sensibly and smartly in terms of where things can actually be achieved in there. But that's a considerable amount of money available from the IF fund, 285,000, and then there's this additional leadership money which is available to support leadership and management within PCNs. And my thought was that was non-recurrent, but I'm not sure now.
It's there because there are some other pots that aren't listed there which have happened as well. So there's transformation funding, for example, which some networks have continued to have. I think all networks have actually listed out. The question is that recurrent or not? Is that funding now going to stop because of what this suggests? Obviously, it won't have the COVID vaccination funds that many networks have taken from last financial year, because that's now coming to a close in terms of this financial year. So there are going to be differences that networks are going to see in terms of pots of funding coming through. And it's important practices know what funding is coming through to their network, because they are obviously members of that network and wanting to know how that works in terms of the financial situation and stability. But it's a fairly big amount. We're talking nearly £2 million for my network.
Yeah, it's a lot of money, and it still astounds me that this is new money over and above the GMS contract. So it does represent genuine investment in general practice, actually, which is really, really welcome. So yeah, it's a lot of money to spend. Although, as we said before, a lot of this is contingent on achieving certain things. It's not given up front to be spent. It's contingent upon achieving certain objectives and meeting certain criteria, particularly around the IAF, and also being able to actually put a bum in a seat and employ somebody to do good work within the primary care network, so it's not immediately available.
Absolutely. So those of you who aren't aware of general practice finance or general practice probably think, oh my gosh, there's £2 million going to the Nottingham City East network. Let me be clear, that's only if you've got people you can actually spend the money on, which has been the challenge for many networks. Bums and seats, workforce is just non-existent at this point in time, and that's where, therefore, that money is therefore then still held by NHS England. And obviously, the immediate question that comes to many people's mind: what happens with that money afterwards if it doesn't get used? Because we know year on year, network by network, very few networks have been able to maximally use their entire ARS budget. That money's still being held somewhere.
Yeah, I mean they do say, right, there's an underspend. Can primary care networks tell us how we might be able to spend this underspend and put to good work? And primary care networks come with plans for that. But even then, there is still an underspend on the underspend. Yeah, and quite what happens to that money, I don't know. I mean, one wonders if it's just returned to Treasury, or is it held within the Department of Health there? I don't know. If anybody out there knows, then please tell us. That'd be really, really helpful to know. And then the final tab is, I think this is information that is just available in other places, like within the network desk itself. But it gives you the tables indicating the sums of money and indicating the roles that you're able to employ within the additional roles reimbursement scheme here. And there's quite a number of roles there now. And also an indication of their agenda for change banding and the amounts that can be reimbursed for those roles, the annual amounts to cover their pay and on costs as well for the primary care network. And then it just breaks out the mental health practitioner separately, and the new role of the children and young persons mental health practitioner as well, which I think, did we have that last year, Gandhi?
So we did, but there was a focus you could have one or the
that was
only
it.
one or the other. Whereas this year, potentially, depending on how you read the letter of the contract, you can have both.
Yeah,
can. If you can find these non-existent people.
Yes, if you can actually find them to recruit, that's the problem. And then it gives, for those people who work sort of in and around the London region, it just gives you the kind of London sort of weightings for funding as well in terms of the ARS salaries. So on the whole, quite a useful document. It's very high level, big picture sums of money. Any thoughts, Gandhi, about its utility?
So I think, first of all, it's nice to have it. Let me be clear on this point. Many times we ask for the Ready Reckoners to give us the information about the financial aspects of things, and we tend not to get these till several months down the line after the contracts have come. This time it's come out at day one. So kudos to NHS England. They've actually given it to us straight away, and it's got majority of the information that many practices and many networks would want to have in terms of what the financial situation looks like. I think there's obviously some caveats with that. That's not going to include all the financial things that come to every practice, because obviously there's going to be additional funds in terms of local enhanced services, private work, or the other kind of things that practices do that is not going to be incorporated. And, fair shout to NHS, that they can't plan for all those eventualities. So this is the main core funding that every practice gets and how you can evaluate it. I think there's a couple of usability things I would have preferred to have been slightly different. The fact that you can't change a couple of boxes and it's not quite clear about a couple of things, and the color scheme, the UI, it's really important. We keep talking about it and stuff. But the big one for me in terms of something that's missing, the ARS calculator itself. So why couldn't we have the ARS calculator, the additional roles reimbursement scheme calculator that we get that's updated with the new modified factors? Why didn't they just include that in this? They know the data, it's available. It would have made life just so much easier. Just stick it in this, and then, because that's one of the things that, particularly for me as a clinical director, trying to figure out and work out in terms of, I've got this many staff and whole-time equivalents for this particular role, knowing where my current budget is, how my budget is tracking if I change to this. That's the document that's really useful. But it needs those modifiers based on the amount of funding that occurs. We've talked about previously about some colleagues of ours at gprota.org who've created their own version of that and is updated, and they update it far quicker than NHS England, which is mind-boggling to me. It really is. But if that had been included with this, then it would have been an amazing, perfectly orchestrated and structured document that absolutely, I'm tipping my hat off to NHS England. They've done it at least, but that's how they could have done it better from my perspective. What do you think, Andy?
Yeah, again, it's nice to have. I think it's a really useful document for indicating what funding is available, which I think is a really good starting point when you are planning your budget going forwards. And I think the key thing is starting point. There's a lot more work to be done, say at primary care network level, to think about how you're going to actually spend that budget, and it will depend on a lot of factors. Oh yeah, we definitely would have liked to have seen the ARRS calculator, which is available in a different document that really helps plan your recruitment much better, taking into account of what you already have, making it clear what you can potentially spend on in the future. So I'd like to see that as well. And just coming to sort of practice level, and again, I think it's a start, and it's about what is available. I think some practices will see their QOF achievement change in a fairly significant way going forwards, given that it's going to be much more difficult to hit some of the immunisation targets going forwards into next year, which this doesn't really flag up for you as you're putting the data in. It just assumes that your QOF achievement is going to be similar to the year before. And similarly, there's lots of other factors that practices need to take into account when they're doing their budget, and you covered most of them, Gandhi. I mean, there is private work, so there's additional income streams that might be there. Might be training practice. You might take medical students. There are all sorts of other ways in which practices supplement their GMS and QOF income. And then similarly, it does not talk about your outgoings or your costs here. And that's the other side of doing an effective budget, isn't it? And those are going to change significantly going forwards, with changes to national insurance, with changes to pay.
Social care levy.
There is just so many ways in which that's changing. And also, things just change in terms of what we need to have in place to deliver care. There's increased access requirements. There is a lot more work to do to achieve some of these QOF points in terms of achieving those quality improvement indicators, and more work that practices need to do to support primary care networks in terms of supervising, inducting the new staff, and helping support with some of the IIF targets. So it doesn't give us the full picture, but at least it gives us part of the picture, and it's good for saying just what's potentially available. So absolutely. I welcome it.
Yeah, no, absolutely. And very clearly from our perspective, it's a useful document, we think, in terms of how practices can use it. I can see one of the criticisms of not including the ARS calculators is that that's more for PCNs rather than for practices. But I think actually even having that information available at practice level is useful, so you can input what you're currently receiving from your network to see the value you're actually getting from your primary care network in terms of workforce. So, that's often something that I think can cause discontent within networks, that they feel they're not having an equal share or all that kind of stuff. Well, actually, you can then play around with it and see what you may or may not be getting, and then actually that can be evidence to show back to your network, say, actually, I'm not getting what I should be doing. It's more accurate in that respect in comparison to other practices in your network. So yeah, nice document, really useful in some ways. Could have been done better, but then we always think things can be done better. So hats off to NHS England, at least for getting it out this quickly. Absolutely, from our perspective.
Good. So I think that probably concludes the episode. We've got a lot more episodes coming up looking at the document drop from NHS England. So look out for what's coming up and over the next few weeks.
And if you've got any questions, let us know. More than happy to hear them, and especially hear them if you can send them across to us. Again, just to emphasize, if you do want to do that, it's speakpipe.com/EGP learning, and the G and the P are capital. The rest of it's all lowercase. And you can send us an actual comment and message and stuff so we can hear what you think about this. Absolutely leave us a like down below in terms of what this looks like in terms of the content and the episode for you. Is it useful? Is it not useful? Really helps us know. And as always, EGP Learning is here to help take enhance your primary care and learning. And we will catch you in the next episode.